The title of this video is Practical Considerations in Treatment Planning. Originally, I had titled this Age-Appropriate Dentistry, but I think the title that I've offered is really more accurate. But let's talk about age. Age is not a major consideration if the patient is mentally aware and physically healthy and able to have the treatment done. Our job on the older patient is to plan treatment that is simpler, less expensive, completed in less time, and less expensive. But then if we think about it, isn't this what all of our patients really want? Unfortunately, we give a treatment plan to patients rather than offer treatment options. And let's talk about the American way. We as Americans want something that's quick and something that's cheap, and often that is not in the best interest of the patient. So perhaps we need to think and change, because this quote from Henry Ford I think is very appropriate. If you always do what you've always done, you will always be what you've always been. So let's think ahead and perhaps do something a little differently. Periodontal surgery. This is surgery to correct anatomical, developmental, and traumatic deformities of the gingiva and alveolar mucosa. And this was an article or definition that I offered in the dental clinics of North America in 1988. And in all probability for residents taking their boards, this is the quote, or rather the reference that they would use for the definition of periodontal surgery. And this is what we're talking about. Restorations, class 5 restorations have been lost in the lateral and the premolar. We see the defective restoration, and periodontal surgery can produce this result. And the simplest root coverage procedure is the coronally positioned flap, not the coronally advanced flap. And on this video, there's some nomenclature terms which are more accurate that you can look up on the web textbook, pdmillerswebtextbook.com. So the coronally positioned flap, just to show you how simple this is, Jennifer Boylan had just graduated from Virginia Commonwealth University when she came to Charleston as a resident in our AEGD program. And this is a case that she did in October, only 5 months out of dental school and under my supervision. We can see the recession here present, and we can see the result about 4 months later after Jennifer did a coronally positioned flap. And there is a category on that on the video which goes into detail of how incisions should be made, how suturing should be done, and I would suggest that you look at that if you want to learn how to do this technique. But let's go back to the case I showed you earlier, and let's see how we approach this. First of all, we went in and removed that class 5 restoration which was defective. And you can see the recession on the adjacent teeth, and there's no missing root structure. So this is an ideal case for the coronally positioned flap. And we can see on the right that after the restoration was removed that there was no missing root structure, but look at the abundance of keratinized tissue apical to that, which can very simply be coronally positioned and produce the result that we talked about before. And this is what I refer to as an ideal periodontal surgery procedure, because the result is so good no one would ever realize that there had been a defect nor that surgery has been done. But what about root caries? In the typical office, these would be restored. But if we go in and remove the superficial caries and the shallow restorations in the central incisors, then we can go ahead and produce a result like this. And the maturity on this probably is only about a month or two. You will notice that there's still a little recession left on that lateral incisor where we see the arrow. But if you will look apical to that, you will see that the tissue is fairly thick, and that will creep down in a matter of months, and you will get complete root coverage. What is the first thing that you should be aware of in treating this patient? And that is the age of the patient. Obviously, this could be a very complicated case with orthodontics, major restorative done, and certainly in a younger patient, say 35 or so, that might be a treatment option that you would offer the patient. However, this patient is 69 years of age, and I think the treatment needs to be simpler, less invasive, take less time, and be less expensive to produce the aesthetic result and functional result that you want. So remember, the patient is 69 years old, and this is the bonding that was done to create an aesthetic result that was pleasing to the patient, which was simpler, less invasive, took less time, and was less expensive. And we're going to talk about the advantages of bonded veneers, because this case is now 9 years old and the patient is 78 and doing quite well. Now, on the upper central incisor, the incisal edge fractured and that was rebonded. What is the beauty of bonded veneers? First of all, they're less expensive. Second, they're easier to do. Number 3, they require less chair time, and very importantly, they can be easily repaired and get a very aesthetic result. But what happens when a porcelain veneer fractures? This is the pre-op view of the patient. This is the post-op view. Did we accomplish what the patient wanted? He has an aesthetic result that was simpler, less expensive, and easier to do. Now let's look at how gumline fillings can complicate procedures. Someone years ago, because of recession, decided to place a class 5 restoration. Now this case is many years old, before dentin bonding was available, so the only thing that could be done was to place a composite. And what do you do when you place a composite? You have to make a preparation with undercuts so that this will stay in place. So look what happened on that. This is after we went in and removed that, and we can see that even the enamel has been undermined, and you can see the concavity, which means that we've got to flap this area. We have to go in and use a burr and flatten that, take the undercut out. And you know what that's going to do? That's going to create an uneven marginal relationship with the other central, which is going to be aesthetically compromising. And here you can see that. But what I want you to see is apical to that, how red that tissue is. And if you want to get the maximum aesthetic result on this, then a graft, for instance, a connective tissue graft, should be placed about this size. And what that will do is that will create what appears to be a root underneath there. The tissue will then be convex rather than concave, and concave tissue reflects light differently and appears red, whereas if you have the convex tissue, it will appear as a normal situation. Is there an indication for a gum line class 5 filling? Yes, and this is a case of GERD, where not only has there been some recession created, but you can see where the enamel has been corroded off. So in this particular situation, class 5 restorations were done, as you see on the right, establishing a cemento enamel junction at the normal level, but yet you can see the recession apical to that. So then we go in and do a connective tissue graft, and this is early healing. And again, please note how thick this tissue is, and by creeping attachment, that tissue will thin out and creep right up to the margin of the restoration. Another thing that we consider that is often overlooked in making simplified treatment is the enameloplasty. And this is simply removing incisal enamel to create a more aesthetic situation. Now, Cathy is a 78-year-old female, and the suggested treatment was extraction of the upper teeth because the teeth were unesthetic and the patient cannot afford crowns. Well, if she can't afford crowns, she's certainly not going to be able to afford implants. The actual treatment was enameloplasty and a maxillary partial in the posterior areas. So this is the way Cathy smiled to begin with, and you can see the uneven incisal edges between the two centrals and the lateral on the slide left, right, which is the patient's left. So what you want to do on this situation is to go in there and make a pencil mark as a guideline where you're going to take a diamond and go in there and even those incisal edges. So this is where we're going to shorten those teeth. And this, you can see, is after it was done. And how long did that take? Probably a minute to a minute and a half. And this is the way the patient now smiles. And can you imagine how much happier she is with a partial denture rather than a complete denture, and not having to have any veneers done on those anterior teeth. And this is a patient that I treated in private practice before referring her back, and I was embarrassed to charge her anything for that because I didn't spend but about a minute doing it. Now let's look at Janie, a 71-year-old patient with a severe extrusion, and certainly there are multiple treatment plans that could be done. But let's see if we can create a treatment plan or suggest a treatment plan that will enable the patient to save at least a first molar occlusion. The MMPPI score on this case scores an 8, and after we're done, you're going to find that it'll score a 6, and so the treatment improves from 81% to 90%, and we will be able to save a first molar occlusion. The first thing we're going to do is go in there and reduce the teeth without anesthesia. And we can see that we can go from there, where there's only 5 millimeters, to here when there's 9. So we're able to maintain those upper molars. We've created space for a treatment plan on the lower. What we're going to do is occlusal adjustment to create space for the restoration. This aids in establishing a more favorable plane of occlusion and is an effective way of treating extruded teeth. But how do you do this? First of all, you do not want to make the tooth sensitive. So you don't want to anesthetize the tooth because you may take away so much and the patient end up with a sensitive tooth. Assure the patient that as you do the occlusal adjustment, at the first sign of sensitivity, that you will stop and reassure them that this can be done. You cannot always get to where you want to go with just occlusal adjustment. In some cases, you have to do functional crown lengthening, as was done on this case by Mary Catherine Gray at the time, who is Mary Lee. And let's look at how she did this. For details and exactly the surgery that she did, there's a video that you can look at on the website. Now this is Helen, a 71-year-old female. And certainly with those extruded teeth, extractions, sinus lift, implants, take out the root tips on the lower, so forth and so on, could be done. But look at the imagination that Mary Lee used on this case and the functional result and aesthetic result that she was able to accomplish. Because here's the chief complaint and why implants were not considered. I have a serious sinus problem and I do not want metal implants put in my sinus. Well, we all know that putting implants in the sinus and obliterating the sinus space may actually make her sinus problem better. But her mind is made up. So what do we have to offer her? First of all, we see these root tips down here, and of significance, they had already had root canals done. Perhaps if they had not had root canals done, we may have altered the treatment plan. Here we see the way the patient looked on the top, and on the lower left, you can see where the surgery was done, the implant placed in the first molar area, and a core buildup done. And we can see on the right the implant in place which is going to provide a first molar occlusion. And who would have thought that the crowns would look like this, and what an aesthetic result the restorative dentist was able to accomplish. But let's look at this. The patient now has a 80% function. And for a patient 71 years old to have 80% function of what she had at 20, I guarantee she's going to accept treatment. But if we look at this, periodontal surgery at $2,000 a quadrant, 6 crowns, including the one on the implant, and the implant itself, $4,000. We're talking about a $13,000 treatment plan. Yes, it probably took a little longer than the implant treatment plan, which cost $27,000. So the patient is happy, the aesthetics are good, the function is good, and as we say, she is going to have over a 90% chance of keeping those teeth in periodontal health based on the MMPPI score. Another case, and you can imagine if this patient went in to Clear Choice, what he would end up with. But his chief complaint, and I think you'll agree with this, he says, my wife refuses to kiss me. And I can certainly understand why. So the only tooth that we're going to remove is this hopeless lower canine here. And we're going to replace that with an implant. The upper central incisor and lateral are going to be removed, but we're going to keep the following teeth. The canine and the premolars on the patient's left, and 2 teeth on the upper and 2 on the lower down there. And then we're going to do a single tooth implant where that cuspid was removed. And you will see the patient is not doing the best job of cleaning, but certainly a better job. And if we work with this patient and put them on the recommendation that I make on oral disinfection, I think we can come up with a high level of plaque removal and a much healthier mouth. So this is the mandibular partial, and you can see the clasp that we've placed on the bicuspid, and we've gone in now and placed the implant, and you can see the attachment in the lower partial. The ring on this can be of different colors, which means it'll take more effort to get it out. But look what we're doing here. Look what an effort he's making to get that out. And do you think now his wife is going to be able to kiss him? I think so. But look how happy this patient is. But if we think through it and think about treatment options, realize that what can be done by conventional dentistry, we need to give patients the option of thinking that way. Let's talk a minute about a fixed versus a removable treatment plan. Obviously, patients prefer a fixed treatment plan. Fixed means they can't take it out, but also there's a psychological appeal to it as well. But let's talk about the advantages of a removable treatment plan. Treatment can be completed in less time quite often. It's much easier to clean and maintain. It can be very stable and functional as a fixed restoration if in fact you've got several abutment teeth and the partial or a removable prosthesis is well planned. Typically it's less expensive, usually will snap to place and not wobble, and it's simple and easier to repair than a fixed restoration. So let's see how this gentleman, what he elected to do. This is an 80-year-old male, and he was offered the options of an all-on-4 in the maxillary arch or alternative treatment, which you'll see that he selected. Now, my girlfriend wants me to get my teeth fixed. He's 80 years old. His girlfriend is 59. So the treatment plan in this case is going to be dictated by the girlfriend. And I want my teeth to look like they did when I was 30. Now, let's take a look at what he looks at now. And he brought this picture in of this is the way he looked when he was 30. This is the way he wants to look. Now, this is a challenge. Now, certainly you could reach that with an all-on-4, but he elected to have something that was removable that did click to place. So this is what we've got on the upper arch. You can see the missing teeth. You can certainly see why an all-on form of the upper would be an alternative treatment, and he was offered that treatment. But on the lower, what do we see? We see two bicuspids down here, and he's got 20% function there. You could go in and suggest a single tooth implant distal of that to give him 60% function, but what he elected to do was to delay that until the treatment was complete and then see how well he functioned, and then he could elect to have the implant and crown done distal to those two premolars. But what is wrong with waiting on that and complying with the patient's desires and perhaps helping them financially? All right, so here's the quote that I was going to come up and tell you about later. A treatment plan is a journey, subject to change if the circumstances change. It requires the flexibility on the part of a conscientious and caring dentist as well as a trusting patient. The patient we are just showing there was a trusting patient. He was given the treatment options, and if circumstances changed and he elected to have that implant done on the molar down there, certainly we could do it. What was lost in waiting on that? We're dealing with a healthy 80-year-old patient, and he prefers a shorter period of time of treatment rather than a longer period of time. Remember, he was offered an implant treatment plan and the fee with that, and he was presented the treatment plan that we're going to show you in a moment. And remember, he's got a healthy mouth periodontally. He scores a 3 on the MMPPI, which means that he has a 96% chance of keeping the teeth for 15 years. What is 80 plus 16? That's 96. The patient wants a removable if we can assure him that it won't wobble and click and will snap to place. And with as many teeth as we're going to retain, we're certainly going to be able to do that. Finances are not a major concern. He's retired military helicopter pilot, and his main job in Charleston is ferrying yachts from Charleston to Fort Lauderdale for the winter, and in the spring going and bringing them back to Charleston. And let me tell you what, he is well compensated for that. Now, in the off season, the winter, he is a ski instructor at Beach Mountain, North Carolina. Now, is that not a heck of a job and a good life for an 80-year-old? And so therefore, finances are not a major concern of his. And his 59-year-old lady friend goes with him on the yacht when he goes to and from Fort Lauderdale. All right, what we're going to talk about, we're going to have an all-on 5, but the all-on 5 are going to be on crowns. So you can see 1, 2, 3, 4, 5 teeth. And you can see on the lower that really did not have to do much. And we did offer the implant on that lower first molar and explain to him the option on that because a treatment plan can vary. Now, the 5 crowns, if they're $1,000 each, was $5,000. An upper partial was $1,500, so the total fee on this was $6,500. However, if we had done the implant treatment plan, 5 extractions, $750, 5 implants at $4,000 each, and an upper hybrid for $2,500 and perhaps even more, but he would be talking about a fee of $23,000 versus $6,000. And let me ask you, would he be better off? And then he said, I don't want to show any metal. So this was a challenge, and this is what we ended up with. And notice that there is metal showing on that clasp on the bicuspid. However, on the inside, you can see where we have left a space in the upper partial where he has natural tooth structure, which will give him better speech. And you can see the partial in place. there's an awful lot of metal there. This is so that it'll have better taste and better sensation and better speech. So this is where we ended up. And as we look at this case from the facial, you really don't show any metal. But here's what's interesting. This is the way he looks when he's through. And he thinks he looks like he did when he was 30. He's had a less extensive treatment plan. His lady friend is happy. So I want to caution you, and not caution you, rather, please give patients treatment options and make the patient satisfied, and don't just force the patient to take the treatment option that you prefer to. Now let's look at a case where the patient was not given treatment options, and let's see what was done. Now let's look at a case where there are multiple treatment options. This gentleman probably is in his middle 60s, and the chief complaint: in private practice, he had had the premolars removed on the upper left or the right on this particular slide. Now let's look at the chief complaint. Since these extractions were very difficult, it appeared to me that they could have been saved. So therefore, I decided that I would come to the university to see if the rest of my teeth could be saved. Let's look at the periodontal tissues. And certainly there's a malocclusion there, but basically the man is periodontally healthy. Here we see the occlusal view, and you will note the extreme wear on the maxillary anterior teeth. This would be an anterior constriction case, and what that is and how that can be treated can be found on the video dealing with occlusion. We see the bicuspid and the molars, and on the side where teeth are present, the molars are virgin teeth. There's certainly, although there's a crown on the premolar. And as we've already noted, significant occlusal adjustment could be done on those extruded teeth to establish a better plane of occlusion. And common sense tells you that probably he had the same thing on the other side, because he said the extractions were very difficult. So this case could very simply have been treated by placing crowns on those maxillary anterior teeth, and with an MMPPI score of a 3, this 60-plus-year-old patient could have very easily had maintained his teeth for another 15 years. However, when he asked if there was a treatment option, the resident indicated that it was not. And the patient hesitated and said, well, before I proceed, let me go home and talk to my wife, because I really would like to save my teeth. After some discussion, because they were at the university where they felt they were getting the best treatment, they elected to have the teeth removed. But look at the amount of bone present there. That's what we started with, and this is where the 5 implants were placed. 5 implants, extractions and all. We're talking about a treatment plan of $18,000 versus having 4 or 5 crowns done for $5,000. So he paid 3 times as much money to sacrifice his teeth. The university should be ashamed, because they went from here to here. And notice that no treatment was offered on the lower. So the patient just had the upper all on 4. So let's go back and see about the chief complaint. Since the extractions were so difficult, it appeared that they did not need to be removed. So I came to the university to see if the rest of my teeth could be saved. Shame on the university. The final case that we're going to show is also an anterior constriction case. Look at the wear on those lower anterior teeth. But crown lengthening was done. Restorations were done. Then crown lengthening done on the upper teeth. And here we see the case that is now, I think, 14 or 15 years old. So it's amazing what we can do if we understand occlusion, if we understand what can be done and if we're willing to share with the patient what can be done and give them the MMPPI score.